it's called sharing content. I call it this first whiteboard, and I'm just gonna write types of synovial joints, just to remind you, to bring you back into context. Synovial joint is a structural classification in which there's a fluid-filled cavity present. Functionally, all synovial joints are diarthrotic. That means fully movable. So, and that's what at least half of this chapter is dedicated to. This types of synovial joints is that I'm listing now is basically centers around the criteria is the types of movement into major categories. And those are the major categories are plane. I'm going to put in parentheses, planar. Same thing. If you hear me say or you read planar, it's the same thing as a plane joint. They mean the exact same thing. Second one on the list, I'm just going in the order of your book, is hinge. That's just like the name describes. Pivot. I'll describe these singularly after I list them. Condylar. These are also known as ellipsoidal. Most of these have Latin names that go along with them as well. Saddle, that's S-A-D-D-L-E, and ball and socket. Those are the major categories of the types of synovial joints. And it's based on, really, what it does is it dictates, the structure dictates function, which is movement. How these move. Now I'm going to say a few things about each one. So going all the way back to plane joints or planar joints, the type of move, first of all, the bones tend to have relatively flat surfaces against each other. Think the carpal bones in the wrist lining up with each other like this, or even tarsal bones in the ankle. The movement, that's supposed to be an O, the movement of plane joints is a gliding movement. Just think side to side. So the bones move this way across, the surfaces move this way and this way across each other. So it's a gliding or side to side movement. Sometimes there's minimal rotation. So I'm going to add that, but it's very minimal. And classic examples of these types of plane joints or planar joints would be carpals in the wrist, some of the tarsals in the ankle, and that means carpal to carpal bone. Now, there's also a description in your book, and I'm focusing on figure 8.1, which pictures all of these as well. And what they do is they picture something like this and describe the movement. They also list how many axes, A-X-I-S, how many axes the movement occurs on. And these are called non-axial movements because there's no revolution around some sort of axial point. That bit, when you see plane, think of relatively cube-shaped or flat surfaces just gliding past one another. All right. Now I'm going to call up a new board to go to the second type of movement. I'll try to go, I don't want to mess up the order. I try to go in the order of your book. The next one was hinge. Hinge joints. These tend to be uniaxial in movement. That means there is a central axis that the movement occurs through or around. The classic example of these hinge joints, the elbow is the classic one. The knee is also a hinge joint, but it's considered a modified hinge joint. So I'm going to leave the classic example at the elbow. And the type of movement that typically occurs is flexion and extension. And just like the name implies, the movement is actually some sort of cylindrical end of a bone like this. Think the trochlea on the humerus, and then the head of the ulna makes this C-shaped claw that wraps around like this. And so we get revolution in this direction around that cylinder. Think of flexing your forearm. And that flexion reduces the angle at the hinge joint. Extension increases that angle at the hinge joint. The next type of joint is a pivot joint. This one's a little less obvious to most people. Rarely does it occur like this in the human body, but there's typically some sort of a post or cylinder with a sleeve wrapped all the way around it. That's how your book describes it anyway. So we get a twisting or a rotation of this bone here. Classic pivot joint example. Oh, first let me tell you that they're uniaxial in movement. That means there's just rotation around one axis here of movement. Classic example of this is where the head of the radius, so I'm going to write radial head. I'll draw a picture in a moment. Radial head, where it articulates with the ulna. So the radial head, I'm going to try to draw it. I usually draw my radius on the left, but I'll draw it on the right this time because that's what your book does. The radial head sort of looks like that nail head, and then it has that radial tuberosity that comes down and bumps out of it. So there's the radius. And it articulates with the ulna. Remember that ulna has that C-shaped claw, sort of like this. This would be, this cavity that I've drawn up here is right in here. That would articulate with the humerus. But the radius and the ulna together articulate right across here. There's a really small short ligament in this fibrous joint that allows the radius to turn in a pivot action like this. So you know that we can roll our forearm both medial and laterally. This pivot position is allowing this rolling to happen. Next on the list is condylar. So to save space, I'm going to squeeze it in here. Think of condyles, that's where the word comes from. A condyle is a projection on a bone surface, a smooth projection that articulates with another surface. There's condylar joint examples all over. I'll try to give you two. First, these tend to act in a biaxial mode, which means they can revolve or turn around two axes, not just one. And your book describes a condylar joint that looks like this. The articular surfaces, if this is one bone, this is an exaggeration. And the other one has sort of a cup-like surface that fits over that convex surface like this. It's almost a ball and socket joint, but not clearly a ball and socket joint, but it's the same sort of setup. This would be the receiving socket end, and this would be the elliptical convex end. One fits in the other. This is where our metacarpals, that's the first set of long bones in your hand, meet the phalanges. So what you and I, if you hold your hand up and you spread your fingers out at the base of your digits, at the base of your fingers, right where they meet the fleshy part of your hand, that's where this condylar joint typically occurs. So I'm going to write, it's called the metacarpophalangeal joint. That's, oops, there's supposed to be an O in it, sorry. AR, metacarpophalangeal. Phalangeal. This also occurs at fingers, but predominantly on the thumb gives us the most of this biaxial movement, but the fingers have it as well. All right, next we've done pivot, and let's do ball and socket. These also move in even more than a biaxial term. It's called multi-axial. Some books say triaxial. I believe your book uses the term multi-axial movement. That allows for, I'm going to put in parentheses, that circumduction movement. So we get all sorts of movements with ball and socket joints: flexion, extension, abduction, adduction, circumduction, rotation, multi-axial movement. And you know what a ball and socket joint looks like. If here's the head of the femur and the acetabulum of the hip, the pelvis, also the humerus at the shoulder, there's the head of the humerus, and here's the glenoid cavity. It's much smaller. The glenoid cavity of the scapula, that's also considered a ball and socket joint. So these are super freely movable in all sorts of directions. Now, I'm going to reiterate this while we're looking at them. Even though these are both ball and socket joints, you can see that the way that the anatomy of the hip joint compared to the shoulder joint, this restricts movement, but makes it a lot stronger. You know, just from being as live as long as you have been, that you can move your upper leg freely, but not nearly as freely as you can your shoulder, your upper arm bone. So this presents much more free rotation, but the compromise is structural integrity is compromised. So it's not nearly as stable. This one at the hip is much more stable, but limit of movement. So that goes over the types. I'm going to say this one more time. There's a figure, I think it's 8.1 in your book, that just pictures these 6 types of joints that I went over. Might have skipped one. I think I skipped, I think I skipped saddle joint.
Yeah, you skipped saddle.
Thank you. So the saddle joint, that is actually truly at the thumb. It's a modified condylar joint. It's considered a modified condylar joint. This one is also, it's biaxial, but slightly more movable than the fingers. Technically, it's still biaxial, but presents an increased movement from condylar. Just to describe to you what it looks like, one, what you and I would call the receiving bone, it gets its name because it looks like a saddle. So there's this U-shaped structure on the end of one bone and a pin almost that sits in like this. And where we find it is the base, what you and I would call the base proximal end of the thumb at the metacarpal, that first metacarpal. All right, so that just describes the 6 types of synovial joints based on their structure. So all of these names, ball and socket, saddle, that's based on their structure. And then that structure dictates the movement of them. And then the last bit of this chapter just goes over specific major joints in the human body. So I'm going to start with those, and I'll go in the order of your book. I think your book picks the knee joint first. Yeah, so we'll do that. So I'm going to write specific joints. I'll say a few things about each one of these. First and foremost, the knee is the largest and most complex joint in the human body. We know it's a synovial joint. And so the anatomy of this, all synovial joints have some things in common and some uniqueness to them. So let's just name some of the commonalities. All synovial joints have what's called an articular capsule, that fluid-filled capsule that's present. Synovial fluid. They all also have stabilizing ligaments. And then to some degree, there's musculature. So the commonality to all these synovial joints is there's a fluid-filled capsule, stabilizing ligaments, and musculature. The hard part, in my opinion, about learning all of these joints is the names of all of these stabilizing ligaments. And that sort of goes beyond the scope of this basic A&P course. So when you read through this chapter, don't freak out, don't get distressed that you're going to have to memorize every single ligament that's associated with all these synovial joints. That's really difficult. That's practically medical school level A&P. I do want you to know what I've written here all contain these three basic constituents. Now I am going to say a few specific things about each of these. The knee joint is it's the largest and most complex, and it's defined as three joints in one capsule. I'll explain what I mean by that. What is meant by that, there's three joints in one, is this. If this is, you're looking at the anterior front view of the femur, that's the distal end. At the knee, I'm going to exaggerate the space so that we can make a joint. Here's the head of the tibia, the lower leg that it rests on. There's articular cartilage on the surface, which is hyaline cartilage, here and here. This three joint in one business just refers to, if you read it, you might not get a hold of this. One joint, if this is, I'm going to put a fibula out here just so we can say this is the anterior side of the right leg. So it's somebody looking at you and this is their right leg. This is considered one joint here between the lateral condyle of the femur and the lateral condyle of the tibia. So that's one joint. Another joint is here, the medial condyle of the femur and the medial condyle of the tibia. So that's two. And the third one, the patella, which sits on top, the kneecap, right here, it articulates with the femur. So now I'm going to write these three joints out. And I'm going to write it like this. The lateral tibio femoral joint. So that would be this one that I circled. The second one is the medial tibiofemoral joint. That would be the second one that I circled. And tibio means obviously a condyle of the tibia articulating with a condyle of the femur. And finally, Number 3 is referred to as the patellofemoral. Joint. And that's where the posterior side of the patella, I'll put the patella in a different color here. So that's red. This is number 2. There we go. So we've identified all of them. This is number 3. That's the 3 joints in one. Now, technically, they all use the same synovial fluid and they're all part of the same compartment, but they're really 3 separate articulate surfaces. So we call this really it's technically, the knee is a modified hinge joint. It's not quite as tight as the elbow, which is a strict hinge joint. The reason is because the knee has slightly more movement. So I'm going to just put this in parentheses, that there is some minimal rotation that can be done at this joint. The last thing, and I don't want to start a new page because I want you to think all about the knee when you're looking at this page. The last thing I'm going to write is the knee, I'm just looking for clear space, has an articular disc in it, which is the meniscus. This joint has the largest meniscus, which is also known as an articular disc. And it sits, I'll use yellow. It sits in here like almost like a thick pancake. It's not completely flat. It actually assists in many ways, this joint, this meniscus. It increases mobility, it reduces friction, it allows for a tighter fit between the bones. So it has all sorts of great functions. I'll talk about damage to that if we have time at the end. All right, so that pretty much takes care of, like I said, I'm not going to have you memorize all of the individual ligaments associated with this because it is super complicated. Before we leave this topic altogether, just know that the cruciate ligaments they're very popular, common. Most of you have probably heard of anterior, posterior cruciate ligaments of the knee. If you haven't, they're often damaged in athletic activity sports. These ligaments specifically lie on intracapsular, so they're inside of this joint. I don't want to mess up my drawing, but those cruciate ligaments tend to look like they make a cross. That's where they get their name, cruciate. And they're inside, they're not out here stabilizing the joint on the lateral. They're actually, let me color code these. The cruciate ligaments tend to be right in here and they crisscross each other like this. That's where they get their name. All right, I'm going to move on to the shoulder joint next. We know that it's a ball and socket from what we just defined earlier. And it's multi-axial in terms of its movement. It's also called the glenohumeral joint. That's for the glenoid cavity from the scapula and the head of the humerus. Ball and socket joints tend to have something called a labrum. So I'll define that for you. A labrum is sort of like a lip of fibrocartilage that extends past the socket. I can't remember if I defined that for you earlier in a different lecture, so I'm going to do it again. It's a lip of fibrocartilage, sort of that extends around the edge of the socket joint, part of the joint. Think of it, it reminds me of like pie crust hanging over the edge of the top of a pie or a pie tin. It kind of does that. If this is the, I'm going to use I'll use the glenoid cavity. So here's the glenoid cavity on the end of the scapula. Here's the head of the humerus. And that labrum is fibrocartilage that extends, not hyaline cartilage, but fibrocartilage that does this, sort of extends past that edge. And it increases the surface area. It helps hold that ball of the articulating bone, helps hold it in place. So it has a labrum associated with it. And then there are ligaments. Remember, there's a fluid-filled cavity, ligaments, and musculature. Ligaments always get their name, by the way, and I'm not going to have you memorize all of them. That's okay. But when you're reading through, I don't want you to skip reading through. When you're reading through your book, the names of those ligaments just refer to the points on the bones where they attach. So for example, there's a coracohumeral ligament in this shoulder joint. That means that ligament, that dense connective tissue, extends from a point of attachment on the coracoid of the scapula to the humerus, to the head of the humerus. So they almost always get their names based on their points of attachment on the bones themselves. There's also glenohumeral ligaments as well that go from the glenoid cavity to the head of the humerus. So there would be a glenohumeral ligament. The coracoid is actually something like that. Remember that finger-like structure like this. And there's a coracohumeral ligament that extends over. You don't have to memorize all those. I was just letting you know that's where their fancy names come from, as point of attachment. This term, rotator cuff. Some orthopedic surgeons say that there's actually 5 muscles making up the rotator cuff. Other sources say there's 4 muscles. So I'm just going to say 4 to 5 muscles in the shoulder that really stabilize this joint. As a matter of fact, the rotator cuff muscles stabilize this joint even more than the ligaments themselves. All right, let's do the elbow, which now you know is a true hinge joint. That means it moves in a uniaxial fashion in a hinge-like movement. This elbow joint is predominantly for flexion and extension. So just bend your arm at the elbow and you'll see what it does. You flex and you extend, and that's pretty much it. It's a true hinge joint, so there's no rotation in that, or there shouldn't be whatsoever. There's all sorts of the same anatomical components. There's a fluid-filled cavity. There are ligaments that are named for the points of attachment. I'm going to show you at the elbow joint. I've done this before when we did the bones themselves, but just to remind you, the distal end of the humerus, this bone, let's do that. I'm going to draw a really short humerus here. And if there's the capitulum, if this is a right arm, this would be the medial epicondyle here. And then there's the trochlea. And how this elbow joint is created, this trochlea on the end of the humerus glides within the head, not actually not the head end, the proximal end of the ulna looks like this. And that's a side view. But if this lip right here, the lower coronoid process, comes up and the rest of this business wraps around to the backside and makes up what you and I call the elbow. So there's the ulna articulating with the humerus. That makes up this pivot, or sorry, this hinge joint. But then there's also some articulation here between the radius, the radial head, and the capitulum. So the 2 points of attachment that make up this elbow joint are the trochlea between the humerus and the trochlear notch of the ulna, and the capitulum of the humerus and the radial head here. And that allows us to bend our arms in this side fashion like this. Just giving you a fun fact. I don't even think this is in your book. Dislocation at, the reason I kept this green, dislocation of the radial head slash capitulum is actually the most common dislocation in the arm of children. Dislocation just means one of the bone becomes misaligned and is considered out of position, out of alignment. All right, we've done knee, shoulder, elbow, hip joint. I think hip joint is last in your book. No, they do the TMJ as well. So let's do hip. I'll go back to black. This is also ball and socket. So it's multi-axial. In movement. You know now that this is made up of the head of the femur, articulating with the acetabulum of the pelvis, of pelvic bones. The movements are flexion, extension, abduction, adduction, lateral and medial rotation, as well as circumduction. So this has the same three constituents of a synovial joint, which means there's an articular capsule, fluid-filled capsule, encased in numerous ligaments that get their names from the attachment points on the bones. And finally, there's musculature, muscles and tendons, stabilizing that joint even more than the ligaments themselves. The only thing I'm going to say about this, the only other thing I'm going to say about this is it has the same types of movement, but compared to the shoulder, limited movement. But it is much more stable. Than the shoulder itself. I forgot to tell you this. It also contains a labrum, which is that lip of fibrocartilage, that pie crust lip around the edge of this sort of overhangs like this. Those labrum, by the way, they can become torn, which can cause pain. Pieces of them can flake off. Labral tears are not that uncommon. All right, we've done some hip business. And finally, the TMJ, which is the temporomandibular joint. This is more complex than most people think, this TMJ. So this is obviously where the mandible articulates with the temporal bone in the skull. I'll try to draw some pictures as best I can. what I'm going to say about this is that there's many, first I'm going to list the movements because there's many more than people think. We have the normal depression and elevation that you and I know when we open and close our mouths. So elevation would be closing the mouth, or let me write that out, elevation. Depression is when we open our mouths. So the mandible goes downward. So we have elevation, depression. There's also protraction, retraction. So when you jut your jaw forward, that is protraction. There's a C in there. Protraction. Retraction is if you pulled it back. We do have some minimal rotation as well. We can laterally glide side to side. So let me write that, lateral, it's called lateral displacement. So there's many more movements than most people think. I'm going to write minimal rotation. And there is a meniscus in this joint as well. There's an articular disc. And that disc in that joint separates. I'm going to put articular disc in parentheses because I do want you to remember those are the same things. A meniscus is an example of an articular disc. In the situation of the TMJ, temporomandibular joint, that separates the joint cavity into superior and inferior subcavities. So I'm just going to go to a new picture here and draw as best I can. There's the mandibular condyle sticking up. I'm drawing a lateral side view of the mandible, the lower jaw. And the teeth would just be down here. And the articulation point with the temporal bone, and it's called the mandibular fossa on the temporal bone, is up here. And then the external auditory meatus, or the ear hole, would be right about here. There's a styloid process that hangs down, that sharp process. And the mastoid process would be covered up by this. It's behind here. So the joint, the TMJ, refers to this area here. That meniscus, that fibrocartilage disc, sits right about in the middle and separates that fluid-filled cavity into a superior and inferior compartments. All of the ligaments that tie up this joint, ligaments in general, their largest function is stabilization. But they also dictate range of motion. So if you think about it, certain ligaments, as they get tightened, they limit range of motion, but then usually the opposing side, those ligaments are loose, allowing for motion in that direction. If you just bend your knee as far as you can bend it, trying to put your heel to your backside, your gluteal muscles, you know that it gets tight on the anterior side of your knee and it's loose on the posterior side. So they stabilize as well as dictate range of motion. They also, the other things that in the human body that dictate and limit range of motion are the shape of the bones themselves, as well as musculature. Muscle tone stabilizes joints even more than ligaments do. So the largest factor, I know I've said this, but it's worth saying, that this means I'm definitely going to expect you to know this for the quiz, that muscle tone, including tendons, tend to stabilize synovial joints more than any other factor. I'll just put most. We know this by injury / physical therapy, that the more muscle tone you have in and around a specific joint, the much stronger that joint becomes. Right, so let's talk about some injuries. And before I talk about injuries, I'm going to say a few things about, if I said this the last time, forgive me, but it's worth repeating. BURSA, if I put an E at the end of that, that's plural, that means more than one. These are just fluid-filled sacs associated with synovial joints. Technically, they're not part of a joint. And they're filled with a fluid that's very similar to synovial fluid. We find them all around the joints. For example, your shoulder joint has several bursa around it. Your knee joint has, I don't know, it's like between a dozen and 16 bursa sacs. That increases flexibility, it decreases friction. This term bursitis, which I'm sure you've heard of, literally translates to inflammation of the bursa. And that's from overuse, typically. And a tendon sheath, I mentioned this, I believe, at our last visit, but this is a tubular-like bursa. That specifically, they encase muscular tendons. And the term tendinitis literally translates to inflammation of the tendon. More than not, though, tendinitis is an inflammation of the tendon sheath. Right, and then your book does mention cartilage tears, which are not uncommon at joints. The most typical place that cartilage gets damaged at a synovial joint are the meniscus and those labrum. So typically, I'm going to write meniscus, those articular pads, the meniscus and labrum, have a tendency, pieces, to tear. So if you think of the knee meniscus as almost like a pancake separating the femoral condyles from the tibial condyles between, right in the middle of that joint, you can imagine that gets squished and pushed and twisted all the time depending on the movements. And pieces of that pancake can just sort of start to slough off and tear. And that protrudes. There's our femoral condyles and tibial condyles. Here's our meniscus. It's actually dual shaped. There's almost one meniscus here, and it's separated by a different surface for that joint. But tears are not uncommon at all. And then pieces can slough off like this and pinch nerves, impede movement. Surgeons typically go in with a laparoscope, which is just a little tiny incision and a fiber optic scope, and they can see in there, and they go in with a teeny tiny snipper and they cut that off. That's typical surgical solution for tear meniscus. Labrum, same thing. If here's the acetabulum on the hip, here's the head of the femur. A labral tear is not that uncommon, where a piece of this labrum just sort of either completely tears off or hangs off like a hangnail on a toenail. And that causes all sorts, it can cause a clicking sound when somebody walks. It's also very painful, and surgeons typically can go in there and snip that off as well. Now, I also want to highlight the difference between a sprain and a strain. A sprain is more serious of the two injuries that I just described, sprain and strain. A sprain is when the ligaments, there's ligament damage to a joint, either overstretching or tearing of the ligaments. The most common places that we get sprains are the lateral ankle and the wrist. Are the two most common areas in the human body. And they're slow to heal. There's tons of inflammation involved with this. They're slow to heal because that dense fibrous connective tissue is not super vascularized. So, protection, rest, icing, compression, all of those things, the typical treatments. A strain is usually muscular. I'm going to write muscular / tendon damage. And a strain typically heals faster and requires less treatment than a sprain. A dislocation, just the name describes what that means. Dislocation is just when bones are forced out of alignment. And the typical treatment is surgical intervention of just realigning the bones themselves. Most common places that we get dislocation are the shoulder. I'll list these. Fingers. The mandible. I'm just going to write the jaw. And finally, I'm just going to say a few things about arthritis. Arthro means joint. Itis means inflammation. So this literally translates to inflammation of a joint. Your book lists 3 types of arthritis. There's 2 major types, osteoarthritis and rheumatoid arthritis. I'll talk about the third one in a minute. Osteoarthritis, or OA for short, is by far the most common type. And it is a wearing away of the articular cartilage on the ends of the bones until we get bone grinding on bone, and that causes all sorts of inflammation and pain. But now the theory originally was it's just from overuse and wearing away of that articular cartilage. Now it's thought that that the release of a certain type of enzymes, that they're called metalloproteinases. Spell that out. These are enzymes. So when we use a joint, when we move it over and over again, it causes the release of these enzymes. And then it's thought quite possibly that these enzymes degrade articular cartilage, especially the protein collagen. I'm going to write collagen in parentheses. And that precipitates the wearing away of the cartilage and the grinding of bone on bone, causing that osteoarthritis. When that occurs, when we lose our articular cartilage, I'm just going to draw a fake joint here. The articular surfaces are aligned with this hyaline cartilage. After that wears away, we get bone grinding on bone. I didn't mean to erase the whole thing. I was just trying to erase the blue. So we get now a bone surface grinding on a bone surface. That creates, the bone reacts to that when there's no cartilage there. And the surface of the bone grows spurs. I'm sure you've heard of bone spurs, which are these little bumps, like osteophytes on the surface as a response to that bone grinding on a hard surface. That can become even more painful. And that grinding sound has a name, it's called crepitus. The second major type of arthritis is rheumatoid arthritis, or RA. Much less common, just as serious, especially if one is afflicted by it, but it's much less common than osteoarthritis. This is an autoimmune disease. What that means is our own immune cells attack our own good tissue. That's what autoimmune refers to. So it's theorized that certain bacteria and viruses may cause this. The cause has not been proven yet. But for some reason, our own immune cells start attacking our own good tissue cells. The current theory behind that is some bacteria and viruses that find their way into our joints. They have surface protein markers on them that are identical. Some of the markers on the virus or bacteria are identical to our own cells' markers. And so our immune cells are tricked into thinking that our own good cells are foreign, are a bacteria or virus, and they attack it. So that's current theory. And finally, this term, gout. You and I just call it gout. Technically, it's referred to as gouty arthritis because it does cause inflammation of the joints. This cause is completely different. So it's from the buildup of uric acid in our fluids. Uric acid is a waste product that comes from the breakdown of nucleic acids in the human body. And typically, we just get rid of this in our urine. We excrete it because it's a waste product. But if we don't excrete it well enough, or there's an overabundance of its production, it builds up in our fluids. And when it builds up, it can form sharp crystals in joints, particularly in that fluid-filled cavity and around the joints. Sharp crystals build up. They're literally uric acid crystals, and that causes a lot of pain. It typically afflicts a singular joint. Males are more prone to it than females, and the theory on that is estrogen helps get rid of uric acid, and females have more estrogen than males do. There's also probably a genetic component involved with it because it does seem to be an inherited affliction, and it most often affects the base of the large toe. And finally, those are the three types of arthritis. I'm just going to say a few things about Lyme disease. Ticks are pretty prevalent in New Jersey, so we've all heard of Lyme disease. This is caused by a bacteria that's in the tick that feeds particularly on mice and small mammals and deer. There's more than one type of tick that carries this bacteria. It's a spirochete bacteria, but typically ticks, the really small ones that feed on deer, carry this most commonly. And this is caused from a bacteria that lives in the host of the tick. And then when the tick feeds, if you get a tick bite, that bacteria can get into your bloodstream. And it can oftentimes cause joint inflammation. Causes other symptoms as well. This one's really tough, Lyme disease, because the diagnostic testing is not great. And so there's a lot of false negatives actually on people who get tested for Lyme. They're tested and they come back negative when they really do have the bacteria. It's also very difficult to get rid of. Typically, treatment for that is long course antibiotic treatment. All right, guys, we are done. I'm going to cut my recording, and then you're free to ask me any questions.